Executive Director, Dean, all faculties in DL colleges. I am Dr. Jogendra Kumar Jogesh, Junior Director from Department of Pediatric Surgery, will be presenting today CPC on the topic abdominal. 8-year male child, resident of Muzaffarnagar, Uttar Pradesh, presented to OPD with the chief complaints of pain abdomen for 1 month and mass per abdomen for 1 month. The child was apparently asymptomatic 1 month back when the child developed pain abdomen, which was incident in onset, dull, achy in nature, pain more in upper part of right side of the abdomen and not associated with food intake, nausea or vomiting, with no aggravating or relieving factors. Also complaints of lump abdomen, which was incident in onset and gradually progressive in nature, involving almost right upper abdomen. No history of fever, no history of loss of appetite, loss of weight, no history of vomiting, constipation, loose stool, no history of jaundice, uritis, no history of increased frequency of urination and dysuria, no history of breathlessness, easy fatigability, no history of trauma, no history of contact with sheep, cattle and dove. Antenatal history. Born to a 25-year-old mother. No history of drug intake during pregnancy. Antenatal scans were normal. Birth history. Full term, firstborn, normal vaginal delivery, cry immediately after birth. Past urine and meconium within 24 hours of birth. Birth weight 3 kg. Family history. Non-consanguineous marriage. No history of diabetes, hypertension or any malignancy. Postnatal history. Immunization. Immunized as per age. Normal growth pattern. Milestone achieved as per age. 8-year male child with normal birth, normal family history with a painful lump in right upper abdomen for last 1 month.
So, to begin discussion, we have a young child with a short history of 1 month with pain abdomen and lump abdomen with no obvious localizing features. Apart from that, there is no jaundice, urinary complaints. So, what could be the differentials if we get such another patient in pediatric OPD? Any pediatric resident? Pediatric surgery resident? Yeah, please come to the dais. Come to the dais. Introduce yourself and make comment.
Good morning, everyone. I am Dr. Noon, pediatric surgery resident. Now, based on the history that we have got, the pain was in the abdomen, localized in the abdomen, and localized to the right side upper abdomen. So, in this age group, we could get hepatic abscess, or could be a hepatic hydrocele in the case of patient, or could be some tumors, possibility of a tumor,
Why do you only consider liver as a possibility? The patient doesn't have jaundice, no fever. You still bring abscess as a possibility?
In the case of hydrated cell, we get patients with pain abdomen and no fever sometimes.
Hydrated, I agree.
Yes.
Any other possibility? Thank you. Any other resident? Any faculty would like to make a guess on possible differentials? Ma'am, would you like to make a comment?
I think it's I mean, if you just go by the way he has given his history, no history of dog, sheep and all, so you start thinking of hydrated cyst, which goes with the slowly enlarging lesion, which could have arisen from liver. We will see in the physical examination if it is liver or not. But there are many other structures which are there in the upper abdomen. And in upper abdomen, even on the right side, you can have lesions which may arise from the intestinal tract, from the duodenum or from pancreas, or sometimes also from gallbladder. And many times you have choledochal cyst, which may present in children. Although they are associated with cholangitis, episodes of cholangitis, which are with fever and jaundice intermittently. Like congenital malformations are anyway thought of more commonly in children, but this is a relatively grown-up child who's 8 years old, so acquired diseases can also be there. There is no fever at all, so an acute inflammation like liver abscess doesn't seem to be likely, because there you usually have acute fever and you have acute pain, which is not there. This seems like a dull aching pain which has been there.
So ma'am, what will be your 3 differentials?
Number one, it can be hydrated. It can be liver cyst as such, but choledochal cyst is another possibility. And a tumor, as he said. Many tumors which may arise from liver, or they may be in the area where stomach and liver are located. So things like hemangiopericytoma, etc. They can also be.
Yeah. So just to add, the triad of choledochal cystis, pain, jaundice, and lump abdomen, which is usually seen in only 20 to 23%, 25% of patients. So the combination may not be there. So a good possibility of choledochal cyst with pain and a lump, which is in right upper abdomen.
Good morning. Good morning.
So your comment should not be because you know the case with this history.
Only sir, I am reading.
Yeah.
Sir, actually mass is asymptomatic and incidence in onset. In pediatric age group, I think first DD on the basis of clinical examination. My DD is first right hydronephrosis.
Right, hydronephrosis.
Hydronephrosis because lump is asymptomatic and only symptom is pain.
So you are bringing in urinary system. So why not a renal tumor?
Maybe with the possibility.
So from liver we are moving to nephrology.
Yes.
Okay, so adding to possibility hydrated cyst, choledochal cyst, right hydronephrosis.
And many are told like pseudocyst of pancreas.
Oh, pseudocyst, mild pain, abdomen, dull aching pain would be very unlikely. Trauma, no history of trauma, no history of pancreatitis. Without pancreatitis, causing pseudocyst would be absolutely unlikely.
And other like retroperitoneal teratoma, maybe possible.
Great. Okay, thank you.
Thank you.
Yogesh, we can move ahead.
Only point I wanted to add is, as we have considered tumors in our differential diagnosis, the thing is that we should not be keeping a tunnel vision of tumors only rising from the liver, because many a times right upper quadrant mass in children, we should always also keeping the DDs of tumors arising from other regimens, RMS, rhabdomyosarcoma, and germ cell tumors may also present as right upper quadrant mass in children.
Okay. So germ cell tumor of what? From just my organ of origin or structure of origin.
We call it as extragonadal germ cell tumor. So sometimes they are also presenting as right upper quadrant mass.
Organ of origin would be what?
So gonad, extragonadal germ cell tumors classically are arising from the gonads, but there is a subset called extragonadal germ cell tumors which may present as right upper quadrant mass.
So
basically germ cell migration.
Okay, carry on. You can carry on.
My DD right hydronephrosis, hydrated cyst of liver, choledochal cyst, liver abscess, hepatoblastoma, neuroblastoma, nephroblastoma, retroperitoneal teratoma.
Carry on.
General physical examination. General condition here: hydration adequate, normal faces, eye normal, no bony swelling along skull bone, spine, ribs, and long bones. Palate present, no icterus clubbing, pedal edema, lymphadenopathy. Head to toe examination was normal. Vitals within normal limit. Systemic examination, per abdominal examination, inspection. Fullness of right hypochondrium and lumbar region. Moves with respiration. Umbilicus inverted and slightly displaced downward. Dilated vein present over abdominal wall, upper half of the abdomen. No scar, pigmentation, skin changing. Hernial orifice or external genitalia appears normal. On palpation, no local rise of temperature, non-tender, mass above 12 to 8 cm, occupy right hypochondrium and epigastrium region, vertically stand below the right costal margin, about 5 cm, medially not cross the midline. Smooth surface, irregular border, hard inconsistency, move with respiration, restricted mobility, head rising test, intra-abdominal lump. Finger cannot be initiated between lump and right costal margin. Dilated vein present on milking direction flow of the below the downwards. Renal angle free, no hernia, external genitalia was normal, spine normal on palpation. Percussion, liver dullness percussed in 5th intercostal space in right mid-temporal line, which is continuous with the dull node over the mass. Liver span about 8 cm. Rest of the abdomen tympanic, no evidence of peripheral. On auscultation, ball sound present, no edible breed. Digital rectal examination, anal opening normal, tone normal, glove finger stained with the stool. Other system within the normal limit. CNS, CBS, respiratory system is within normal limit. 8-year-old male child with normal birth and family history with painful lump in right upper abdomen for last 1 month. On examination, hard, non-tender, immobile lump of size about 12 into 8 cm, occupy right hypochondrium and epigastric region, not crossing the midline with free fluid.
So the only thing which examination adds is that the mass is possibly arising from the liver. So renal masses are out, likelihood. So now, can we narrow down our differentials? Would you still keep a possibility of choledochal cyst? First question, does it bring in liver abscess as still a possibility? Because you have kept one of the possibilities as liver abscess. And what could be the other differentials? Any comments from residents? Any pediatric surgery resident? Rohan, you made a comment. Would you like to add anything? Come to the dice if you want to add. So now your mass is localized possibly to liver only. So will you keep two possibilities, choledochal cyst and liver abscess, with the current findings?
Liver abscess to be less likely because this in terms of fever not there anymore of that. I'll go more because they were dilated veins, so I'll go more towards the tumor side. And hepatic heart attack could be kept as a possibility. And choledochal, yes sir, we can keep that as one of the possibilities.
So I would like to keep a possibility of Butt-Chiari syndrome in this case. You have a liver which is enlarged, you have veins which are dilated with the flow below upwards. The only point against Butt-Chiari will be absence of ascites. But in a clinical scenario, you can have. So my clinical possibility will be definitely Butt-Chiari. Yeah, ma'am. So okay.
Now the feel of the mass is not cystic. So many of the cystic lesions, especially choledochal cyst, seems little less likely. And the mass seems to be solid and by the firm feel of the mass, and it certainly is arising from liver. By most of the description that it is from the liver, it's in the right hypochondrium and also in the epigastric region. So it is from the liver. So liver abscess is out because no fever and no tenderness is there. So tumors, I think, are still very likely, and tumors which arise from liver would be likely, like hepatoblastomas or And parasitic infections you can't really rule out. Sometimes they, with infection, or they may feel like solid, and some of the hydrated cysts can be multilocular also, because this Echinococcus multilocularis sometimes presents like that. So those two possibilities, tumor first and parasitic infection second, would be now. You asked a question about Budd-Chiari syndrome. Budd-Chiari syndrome can occur secondarily also, mostly secondarily, which can occur in liver abscess. So it's described in liver abscess because of the compression of the hepatic vein. So that may be there. Otherwise, you can't explain these dilated veins and with flow upwards. So whether there is a functional IVC obstruction, that is another possibility, but there is no ascites at all.
So I think we are localizing to two differentials. First is hepatic tumors, and second is hydrated cyst, but the mass appears to be very solid in nature. Now the question comes in terms of discussion, no weight loss, no loss of appetite. So are we talking of a benign tumor or are we talking of a malignant tumor? Any comments on the differentials of the tumor in this case? Any pediatric resident, pediatric surgery resident? So 8-year-old child, what would be the first possibility as a tumor, a liver tumor or a hepatic tumor? Benign versus malignant. So hepatic adenoma?
Hepatic adenomas
Could it be a hemangioma? Could it be focal nodular hyperplasia? Could it be hepatocellular carcinoma? Could it be hepatoblastoma? So what could be the differential of this mass?
So hepatoblastomas, the peak age would be averaging around 2.5 to 3 years of age.
And this child is 8 years.
8 years old. So the other benign tumors that could happen would be hepatic adenoma. Another vascular tumor that could happen would be epithelioid hemangioma. And focal nodular hyperplasia, it occurs in a pubertal age patient. Hepatocellular carcinoma occurs in an age group that is post-pubertal, more commonly seen in post-pubertal age groups.
So your first possibility, are you considering benign or malignant?
So as the features of fever, anorexia, weight loss are not there, a benign possibility could be considered. Tumor could as well be benign, sir.
So you believe it's more benign than malignant? In benign, first possibility?
Epithelioid hemangioma.
Epithelioid hemangioma. And in malignancy?
Malignancy, hepatoblastoma. Hepatoblastoma would still be more likely when compared to hepatocellular carcinoma in such an age group.
Can I ask a question? Normally in adults, hepatocellular carcinoma occurs in the setting of cirrhosis. So what is the data in pediatric population? If anyone can answer that. Dr. Amit, you can please take your seat.
So classical pediatric hepatocellular carcinoma may not present with background of cirrhosis, but we expect that there will be chronic pathology that can be infective, even congenital abnormalities can be background of developing HCC. Now regarding history, anorexia, weight loss, the classical adult symptoms might not be present in pediatric malignancy. So by default, we don't expect that a child will be emaciated, especially in this age group, less than 6 to 8 years old. So we don't expect that child will be having anorexia, weight loss, emaciated. Usually they present with just incidentally notice abdominal lump. For example, most common presentation can be just mother is just helping child to bathe and she notices some lump. So that is one of the most common presentations. So this should not be taken that in pediatric malignancy we are expecting only anorexia, nausea, anorexia, weight loss. That's going to be the malignancy. First thing. Second, HCC in this age group is not a common diagnosis. Similarly, hepatoblastoma is also not a common diagnosis. But if given a choice, hepatoblastoma should be a more likely possibility as compared to HCC. HCC, even in pediatric, that will come with some background liver disease. So not necessarily classical 10 years of history of cirrhosis, but there will be some background of liver disease.
So what are your possibilities, Dr. Amit? If you have to enumerate 3 possibilities.
So academic teaching point of view, all the findings are towards benign, but we will also like to keep a maintenance.
3 possibilities. I'm putting you on spot, but I want 3 possibilities, if you can.
Most likely it's benign tumor only. But second, which should be actively pursued, that should be diagnosed with hepatoblastoma, even in 8-year-old child.
Okay. Anyone? Yeah. Please go to the slides. Introduce yourself and
A very good morning to all. I am Dr. Shaurya Katya, Senior Resident Pediatric Surgery. Sir, I just wanted to comment, won't the rapid rise in mass, that won't point towards malignant side of the mass, sir? So because the history that the mother gave was that she absolutely didn't notice any mass 1 month back, and then there was only slight distinction, and then within over 1 month of time, there was sudden increase in size, and now the masses that it is occupying whole of right upper abdomen. So will not this point towards
how will that help you?
So, towards more pointing towards malignancy than a benign.
So, Shaurya, what are your differentials?
I think I would keep hepatoblastoma. Still hepatoblastoma, because incidence also that we have seen, we rarely see a benign pediatric liver tumor. We have seen more of hepatoblastomas.
Okay, so your only possibility is hepatoblastoma?
Not only, sir, but if 1, 2, 3, I will maybe keep hepatoblastoma.
Any comments on pediatric surgery faculty? Come to the lights, come to the lights.
Good morning. Any mass in this age group, especially is coming to B. Would like to, this mass was on the right side upper abdomen and involving almost half of the right side of the abdomen. So the common possibilities should be hydronephrosis, hydrated cyst, choledochal cyst, and then in malignancy you should think about all this, hepatoblastoma, maybe renal mass, or these two will be more common in malignancy. But as far as this benign condition are concerned, I would like to put first hydronephrosis, hydrated cyst.
With same findings, you still like to keep a renal mass?
Yeah, definitely. You can see the renal mass with a dense, huge renal mass involving almost half of the.
Interesting. And so your
even complete abdomen, even in female ovarian cyst, you can see.
Dr. Inzam, with this case, what are your 3 differentials? 1 to 3.
In this case, I will keep definitely as this patient, especially in this patient.
Yeah, we are talking about this patient only.
When I saw this patient, he was having some dilated visible veins on the anterior abdominal wall. So in this case, I would like to keep first malignancy, because dilated visible veins means there is some vena cava obstruction. And vena cava obstruction means something is compressing or engaging the vena cava. So in this case, I would like to keep malignancy first.
Thank you. Any other comments, or should we move ahead? Chelly. Let's see your differentials.
Differential diagnosis: hydrated cyst, point in favor or point in against. Point in favoring endemic area, palpable lump, pain abdomen. Point against it, no contact history, rapid increase in size, no cystic lump. Choledochal cyst, age less than 10 years, palpable lump, pain abdomen. Point against it, no jaundice, no fever, rapid increase in size. Liver abscess, tender lump, pain abdomen. Against it, no sign of toxicity, no fever, and no loss of weight. Hepatoblastoma, point favoring rapid increase in size, palpable lump, pain abdomen. Against it, age more than 5 years, no weight loss, no anorexia, no jaundice. Hepatocellular carcinoma, age more than 6 years, palpable lump, pain abdomen. Point against it, weight, no history of weight loss, no anorexia, well preserved child. Retroperitoneal teratoma, large palpable lump in favor point, or point against him painful lump and irregular lump.
So all your possibilities are liver related, which we expect, hepatobiliary. So of all these, which will be of final clinical diagnosis after history and examination?
Other investigation was done.
Okay, carry on.
Initial blood investigation, hemoglobin is lower side 7.4 gram per deciliter or other within normal limit. Liver enzyme is elevated, ALP or GGT, ALP 558 or GGT 2.277 unit per liter. Tumor marker within normal limit. Serum LDH 378 international limit, beta HCG 0.95 international limit per liter, AFP 42.9 to 42.1 nanogram per ml.
So this is getting interesting.
It should be less than 10.
Alpha V2 protein.
Is 42, is it elevated?
Ma'am,
That is a reference age.
ma'am, in adult less than 10 nanogram per deciliter is ml is normal.
And in children?
In children, ma'am, this age group is normal, ma'am. Of the tumor marker is more than cutoff, ma'am, more than 100 nanogram per ml. So,
Then you think of protein.
yes.
This is normal.
Yes.
So now, just wait. So now this is becoming interesting. And you would like to add what are their differentials? So hepatoblastoma, hepatocellular carcinoma out, alpha V2 protein.
No, hepatoblastoma is not out.
Okay,
80% of hepatoblastoma they don't have elevation.
okay. For classical cases.
Yeah.
We are talking of more of classical.
Classical cases also.
Age itself says it's not classical hepatoblastoma. So that is still at
So this patient has anemia. This patient has slightly raised TLC. Is still the possibility of liver abscess with butt carrying is coming up? Because we know that chronic abscesses can happen. Patient has taken over-the-counter antibiotics and it becomes a more indolent course. So, treating faculty, your comments? With this investigation, I'm still not going on radiology.
No, sir, but
Come to DICE if you want. And then followed by SR pediatric surgery.
regarding hepatoblastoma, reference range is 100, lower than 100 or more than 100. And in case of other talk to like histology pathology, in patient with hepatoblastoma or renal tumor, if there is a alpha V2 protein less than 100, then should keep possibility like small cell undifferentiated rhabdoid tumor and sarcoma and other fibroluminar hepatocellular carcinoma.
Thank you. Dr. Shore. Your commentary is regarding alpha V2 protein.
Yes, sir. So I would like to comment that AFP is initially raised in neonatal period, but as the age progresses, by 1 year, the child, the normal range that is given is less than 10 nanogram per ml. So in age more than 1 year also, if it is more than 10 nanogram per ml, then it is raised. But if we are talking with reference to hepatoblastoma, then definitely this is a low AFP, and then other variants that we'll subsequently see in histopathology, that they should be kept more in mind as compared to the other variants that are the rare variants that come into picture.
So according to you, this is elevated AFP?
This is elevated AFP according to the age of the child.
Okay.
Thank you.
So this AFP is actually an issue in this child. We also had a discussion. So in 8-9-year-old, 42 you are not going to ignore. That should be the message. So even if you are considering that to be it's normal, above normal, this is not normal in this context. Child is having hepatic mass. We are suspecting hepatoblastoma. Age is 9 years. Then it's more than 4 times at least upper normal lab reference. So this is not normal in the clinical context. And that 100 cutoff is risk stratification, not just for diagnosis. So that should not be taken as a message that only more than 100 is diagnostic.
No, Dr. Amit, I'm a bit confused with contradictory statements being made here. So for this child, what is the normal AFP levels?
Within lab reference range.
So
Sometimes some lab can have 4 also. In this context, the lab reference range that has been quoted is 10. So less than 10 is going to be normal in this child. But child is having mass, lump, liver lump, we are expecting that it can be a...
So, but our lab references are in terms of adult references. So in adult, I know that it's 10. But this is a classical pediatric child. So alkaline phosphatase is different from adults. So in an 8-year-old child,
This is not normal.
this is not normal.
That should be the message.
Okay, thank you. Yogendra, you can carry.
Other radiological examination. Kindly, Dr. Abhishek.
Yogesh, join me here.
Good morning, respected Director ma'am, Dean ma'am, respected faculty and my dear colleagues. I'll be presenting the radiology side of this case. Contrast enhanced thorax.
What was the ultrasound finding?
So, ultrasound was not from my side.
Patient had come with an ultrasound recently from outside.
Yes, ma'am.
Can you just stand until this ultrasound findings?
So carry on.
Contrast enhanced thorax and abdomen was done in IPD setting of our department. Discussing the abdomen findings, we could see an ill-defined.
Use the cursor.
We could see an ill-defined heterogeneous mass which was arterially hyperenhancing and which was showing washout on delayed phases with internal non-enhancing areas. Some foci of calcification were also seen within the mass. So as I was saying, an ill-defined heterogeneous mass which was arterial phase hyperenhancing and which was showing washout on delayed phases. It had some internal non-enhancing areas and few foci of calcification within. Here we can see that there was capsular irregularity involving segment 5 and 6 and mild perihepatic field fluid, as I am pointing out, was seen. Also, there was mild right-sided pleural effusion noted. This was pointing out that the heterogeneous mass had ruptured and reached the capsule. Multiple heterogeneously enhancing lesions were also seen outside the liver capsule, one of them pointing out abutting the segment 8. This was showing extracapsular spread. Here we can see that this is the main portal vein, its right branch, and distally when we traced it, it was attenuated or encased within the lesion. Our query was portal vein was the right branch, the anterior branch of right portal vein was involved by the lesion. Here we can see this is the intrahepatic IVC and the intrahepatic IVC was compressed by the lesion. However, no film defects were seen within the IVC. The 3 hepatic veins arising from the IVC. The right hepatic vein distally was encased or attenuated by the mass. So, from a radiological point of view, the summary is an ill-defined heterogeneous enhancing mass in the liver with extracapsular spread rupture and multifocality as described. Our differentials were hepatoblastoma and HCC.
What is the size of the mass?
So the lesion was measuring approximately 13 into 13 into 13.5 centimeters.
So pretty huge mass.
Yes.
So we have a SOL within the right lobe with multifocal other small lesions,
Yes.
compressing IVC,
Yes, sir.
and involving right branch of portal vein.
Yes, sir. And
Hydrated totally ruled out.
sorry.
Hydrated cyst is ruled out.
Yes, ma'am. The mass was arterial enhancing and showing washout on delayed phase. Typically, hydrated will present as a well-defined mass with fluid attenuation or multiple internal septations and maybe enhancing work.
So why radiologically hepatoblastoma is first possibility and second possibility is hepatocellular carcinoma?
So both possibilities are very good differentials radiologically, but considering the age of the child, sir, and there was no background of any liver disease, so we kept hepatoblastoma as the first possibility.
So according to you, underlying liver is normal?
Yes.
Okay, thank you. Correct. So now definitely we have a SOL liver which appears to be malignant, multifocality involving right branch of portal vein, and our Budd-Chiari part prominent veins can be explained as ma'am said. So as Dr. Inzar said, he'll keep a malignancy as a possibility. So hepatoblastoma versus HCC. Proceed.
Then again, true cut biopsy was done. Then after histopathology, Dr. Anuspal.
Come in.
Good morning to all. I am presenting the histopathology part of this case. Here we see the multiple layers soft tissue core biopsy ranging in length from 0.1 to 0.5 cm, all emptied as A1. On the scanner view, we are seeing multiple fragmented core of liver biopsy showing tumor tissue only. There is no normal liver parenchyma identified. On a little higher magnification, we are seeing tumor cells resembling the hepatocytes of fetal liver, that is known as hepatoblast. No portal tracts are identified here. Here the tumor cells are arranged in cord-like structure on solid sheets. These are the cord-like structure, and the solid sheets are arranged. On higher power, we are seeing this cord-like structure, and cytoplasm is clear with small round nucleus and indistinct nucleoli. So, on the basis of histomorphology, possibility of hepatoblastoma fetal type is considered. A differential diagnosis will be rhabdoid tumor, nephroblastoma, neuroblastoma. To confirm the diagnosis, we did the ISC. On ISC, alpha P2 protein.
Can I interrupt you? Can you go back to your differential slide?
Yes, sir.
When you say nephroblastoma and neuroblastoma, are you saying that nephroblastoma with liver mets?
Yes, sir.
Okay.
So, AFP is positive, glypican 3 is also positive, pan-CK is positive, beta-catenin IC is negative, INI-IC is also negative, WT1 negative, IC is also negative. So, on the basis of IC and histomorphology, features are of hepatoblastoma fetal type. This INI negative IC shows a poor prognosis.
Can you just tell us the significance of all these markers which you have done?
So, this alpha P2 protein is positive in the embryonal or fetal types of hepatocytes. Is positive, normal liver hepatocyte is not positive in this. And this beta-catenin is negative. It shows beta-catenin is mostly positive in hepatoblastoma, but in well-differentiated or hepatoblastoma fetal type, beta-catenin is negative. So that's why fetal type hepatoblastoma we have considered. And this INI is for the prognosis, and this is negative, giving a poor prognosis.
And glypican is for hepatocellular carcinoma?
Sir, it is also for. Yes, sir, but it is negative. It is positive in this hepatoblastoma fetal type.
Okay. So your final pathological diagnosis is?
Hepatoblastoma pituitary.
Thank you.
So regarding lipocalcity, it can come positive in both hepatocellular carcinoma and hepatoblastoma. Even AFP can also come positive in hepatoblastoma as well as hepatocellular carcinoma. Fancy K is positive because it is of epithelial origin. Beta-catenin is seen generally in hepatoblastoma but absent in pituitary. Other possibility based on history, a pancreatoblastoma comes positive for beta-catenin and it is very much near to the liver. So to rule out that also, a beta-catenin was done. INI was done for prognosis. WT1 is a marker for Bell's tumor, that is nephroblastoma. To rule out that, we did WT1. And just based on all these possibilities along with histomorphology, we gave a possibility of hepatoblastoma favoring over hepatocellular carcinoma because hepatocellular carcinoma will have a more pleomorphic morphology. They will appear more atypical. These cells are not that much atypical, which is seen in hepatocellular carcinoma. Hepatocellular carcinomas have large nuclei, presence of macronucleoli, which was not seen in this case. So that's why a possibility of hepatoblastoma favored over hepatocellular.
Any comments from medical oncologist? Okay.
So this was exactly my comment. So just based on IEC, we are not going to move forward. The first step is gross histopathological appearance. The gross histopathological appearance is not favoring HCC anyways. So that's why the whole clinical context is still again that is more fitting with hepatoblastoma than HCC. And then we move forward for IEC to confirm our clinical and gross histopathological confirmation. So that is also collaborative that it's more likely hepatoblastoma. So this should be other way around, like gross histopathology first, which is more likely hepatoblastoma. There are certain findings which are against HCC, and then IEC also contributing into the context. Now, my other comment was for our radiology colleague. So, if you are suspecting hepatoblastoma, why you not reported pre-text? That is standard of care. So, by default, you should report pre-text. Now, otherwise, clinician is not going to plan anything. Pre-text is hepatoblastoma staging.
We gave that in the result.
By default, that is not.
Sir, actually, we gave that in the report. Pretext 2 was there and EFR positive was there. I missed it.
So that is important for clinical discussion.
Dr. Amit, I'll moderate the session. So, for just our knowledge, what is pretext?
Sir, pretext stands for pre-treatment extent of tumor. Before the treatment, when we stage the disease, it's important to actually tell. So there are four pretexts. One according to the size and the occupancy of the lesion. There are pretext 1, 2, 3, 4 based on coinute segments. The liver is divided as left lateral segment, left medial, right anterior, and right posterior. If only one segment is involved and other three are free, that would be considered pretext 1. If 2 segments are involved and the other 2 adjoining sections are tumor free, that would be pretext 2, and subsequently pretext 3 and 4. So in our case, the segments 5, 6, 7, 8 were involved, so it came out to be pretext 2. And multiple other features we also have to give in pretext. The current one being followed is 2017 edition of pretext, in which we give E stands for extracapsular spread, which I described. S stands for multifocality. Multifocality will be explained like multiple liver lesions, and in between those there will be normal intervening liver tissue.
So you do not use LIRADs in pediatrics?
No, sir. Sir, if you are suspecting hepatoblastoma,
Okay. Yeah. No surgery. So we have military hospital Roorkee with us.
Good morning, everyone. Just in briefly about these 2017 SIOPEL risk stratification of hepatoblastoma. The guidelines basically classify hepatoblastoma into 3 risk categories: standard risk, high risk, and very high risk. Standard risk would include pretext 1, 2, or 3 on the basis of our previous discussion, along with no vascular involvement, defined as either the involvement of hepatic veins or the involvement of portal vein, with no extrahepatic disease or no metastasis. whereas very high risk would include diseases with presence of metastatic disease or very low AFP, that is less than 100 nanogram per ml. High risk would include those diseases which are not meeting either the criteria of standard risk or very high risk. So on the basis of this risk stratification, we diagnose the cases hepatoblastoma, very high risk, pre-text stage 2, with annotations of E+, F+, and R+, E standing for extracapsular spread, F for multifocality, and R for capsule rupture. So as cisplatin, doxorubicin, and carboplatin, that is as part of the SUPERPLADO regimen, we did the pre-chemotherapy workup. For the cardiac evaluation, we got a 2D echo done, which was within normal limits. PTA for eligibility for cisplatin, that was also within normal limits. However, the child's LFTs were deranged. Enzymes were in the range of 300, which is more than almost 6 times the upper normal limit. Also, he had anemia, which was worked up, and blood transfusion was done. His performance status was also poor. Lansky Play Performance Scale score of 40, which was almost moderate to severe restriction. In view of this poor general condition, high-risk consent was taken. Patient was started on overnight IV hydration along with anti-tumor lysis measures. His BSA was found to be 1.11 meter squared. Creatinine clearance was 112. So we started him on pre-cisplatin hydration for 6 hours with potassium chloride, magnesium sulfate, and calcium gluconate, followed by the administration of the pre-medications, dexamethasone, ondansetron, and ranitidine. Our total dose of cisplatin 80 mg was infused over 24 hours with concurrent IV hydration. IV hydration was also continued for 24 hours after.
So this is hepatoblastoma. Histology wise, though it is favorable histology, fetal type, low mitotic activity, but there is low AFP, and the child is also not firstly not tolerating chemotherapy well, and next not responding well to chemotherapy. So to a child older of this age, that is 8 years, we have seen child of much younger age, like 2 years, 3 years, but of such older age we have yet not experienced. I think this, by the time I joined, this is the first case that I have seen of such older age. And one another case is admitted in medical oncology department. She is a 17-year-old female child, and the pathology turned out to be hepatoblastoma.
Thank you. Dr. Amit.
Last few comments. So number one, as such, that's why we are saying it's a high risk. So the message is going that the child is not responding to chemo. That's not the scenario. Actually, child is not fit for chemo because she developed COVID and liver functions were more than 7-8 times deranged in baseline only. So to start with, child was not fit for therapy. That is the main issue. It's not like that patient is not tolerating chemo. First thing. Secondly, intent of SUPERPLADO is to cytoreduce so that child can be operated. So that intent is extensive. Like we need to be more aggressive. So that is the basic idea of offering SUPERPLADO. That we are not able to offer in this child. If, other than anything else, that means child is a palliative candidate. That means whatever we are doing, we are just trying to extend the survival. So if we are not able to offer SUPERPLADO with full doses, then child is by default is a candidate for best supportive care or just a palliative intent therapy, so that we can extend some meaningful survival for just, for example, for a couple of years or few months on. So intent is hardcore palliative in this context, right?
Thank
and
you.
same is the scenario with that 17-year-old female. That she is also palliative because she is not fit for therapy yet.
Professor Meenu Singh.
Just one question. I think this was an incidentally positive COVID which was detected and the patient symptomatic. So how does presence of COVID modify the therapy, and how long do you wait for the COVID to settle down? And sometimes patients may be even asymptomatically detected to be COVID positive, because these days a lot of infections are going on. We don't really know which patient would be positive for COVID. So that is one question which I have about this. And the rest is, any role for surgery in this patient? Any initial or
So COVID as such is not contraindication for chemotherapy in solid tumors. So there is a major concern if child is having symptomatic COVID positive status. So background of liver dysfunction, poor performance score, and add on symptomatic COVID. So that was the reason. And still that was after we have offered standard baseline 80 mg per meter square of cisplatin. So chemotherapy was, standard chemotherapy was already given. Then patient was diagnosed with COVID. So actually even if child was not diagnosed with COVID, there was no difference in management outcome as such, because we already offered cisplatin, which is actually one of the most effective drugs. And in terms of surgery, there is no role of cytoreductive surgery as such. For example, there are various scenarios in which we can try to cytoreduce. Even if we are not able to take out all the disease, we can try to cytoreduce. We can take some part of it and then we can continue chemotherapy. That's not the scenario with hepatoblastoma. We need to completely take out everything. That means R0 resection is going to be curative. Everything else is going to be palliative.
So, is there any role of Dr. Amit
Can you come to the dais and ask question?
Is there any role of any alternative treatment like?
Can you go to the dais and ask question, Dr. Intizar?
So that also, because child is having poor performance or deranged liver function, I don't know, my radiology colleague will be happy to intervene in that case.
Repeat your question. Yeah, is there any role of, as this patient is not tolerating the chemotherapy well, patient is sick, is there any role of some alternative treatment like angioembolization?
I don't know, I am just diagnosed with so Dr. Udit and Dr. Pankaj can do this.
So just to add to what you...
Tumor is very vascular.
So it may respond to it.
I don't know, sir.
So what Dr. Intizar is asking for a procedure which is called as TACE, transarterial chemoembolization. So considering the size of the tumor, it would be extremely difficult for him to undergo a TACE-like procedure. And because it's a multifocal disease, then you need to... So TACE is more for the localized disease. I think his liver functions were not that bad, so but the size was pretty large to undergo.
What is the role of a PET CT in a situation like this? Do you want to investigate whether there are any distant seedlings or metastasis, and because that will modify your therapy, I think. And are there any advances in liver tumors using these theranostics, when they try to use some antibodies or drugs which are loaded onto radioisotopes?
So Dr. Amit, this will be your last comment.
Yes, sure, sir. So hepatoblastoma mein PET CT is not a standard of care because that's not going to add to anything. So even if we are getting something on radiology like CT scan, we will take it metastatic and we will proceed with line of management accordingly. So PET CT is actually not going to change our line of management. Or for example, that's not going to help us whether we are going to proceed with surgery or not. And everything else is for now is just experimental only. There is no standard of care theranostics for hepatoblastoma as of now. In future, we can expect that something tagged with AFP might be useful, and that will be useful only with those patients who are having higher AFP levels. And that is also not applicable in very high risk hepatoblastoma. So as such, theoretically speaking, theranostics is also not very helpful in this child. Even if you are trying something experimental.
Thank you. So we had an interesting case and an interesting discussion about how to approach a patient with liver SOL and how to diagnose and manage these cases. Thank you all for your active participation.